So according to severity of the illness, there will be different pattern of thyroid function test. Like,
chronology, is there any chronology of determinant of thyroid function? Initially, T3.
Yeah, that's the graph shows initially in mild illness, like initial sickness of the illness increases, the thyroid function pattern will be changing. Like in mild illness, there will be initially T3 reduction. That is called as low T3 syndrome. Most common pattern is low T3 syndrome. Then for further on worsening of the sickness of the syndrome, T4 will be reduced. Low T4, low T3, low T4 syndrome. Then on recovery, gradually TSH will be normalizing. Sometimes it can minimally elevated. Then T4 will be normalized in the on recovering stage. That's according to the severity of the illness. Thyroid function status will change. The same diagram, when in a mild illness, initially there will be a reduction in T3 only with the TSH normal. Then in sickness increases, moderate illness, moderate severity, there will be T3 and T4 will be reduced with the TSH also reducing. Then as the sickness increases, very low T3 with T4 also reduced. And gradually on recovery, TSH will be increased. Minimal elevation of the TSH with gradually improving the T3 and T4. In this condition, reverse T3, that is a non-functional T3, that will be increased. I will describe how it will happen, Diogenes mechanism, how it is converted to reverse T3 later. Is there an Indian study conducted in Trivandrum Medical College of the prevalence of sick euthyroid syndrome status in ICU patients admitted with sepsis. Of this, portion of sick euthyroid syndrome patients with sepsis was 71% of ICU admission with sepsis. 71% of the patients showed TFT pattern of non-thyroidal illness. The most common pattern of sick euthyroid syndrome was low T3. That is initial pattern. That's only T3 is reduced with the normal T4 and TSH. That was shown in 54% of the patients admitted with the ICU with the sepsis. Then the next common pattern was low T3 with the low T4. That is in most sick patients with a normal TSH. That was seen in 6% of the patients. Then 5% of the patients, low T3, low T4, and low TSH was seen. How this is happening? Pathogenesis of this non-thyroidal illness. There are many mechanisms happening at various levels of this thyroid pathway, like changes in hypothalamo-pituitary thyroid axis. That may be due to illness, infection, and starvation status. Then changes in the peripheral thyroid hormone metabolism, like change in thyroid binding proteins, then transport into tissues, then deiodinase enzyme activity difference, then also in the nuclear receptors. In all these areas, there can be changes. The normal hypothalamo-pituitary thyroid axis. Hypothalamus, TRH is secreted, acting on the pituitary. TSH is secreted, acting on the thyroid, secreting T4 and T3 on peripherally acting. Then when the T3 and T4 has increased, it has a negative feedback. It will act on TR beta 2 receptor in the pituitary and hypothalamus. So it will be a checkpoint like it will control the T3 and T4 amount. There is a negative feedback. This is the normal hypothalamo-pituitary thyroid axis. What happens in non-thyroidal illness syndrome? We can change in the hypothalamo-pituitary axis in the non-thyroidal illness syndrome. There will be sensitivity of the TSH is reduced to T3. That is usually when the T3 is increased, it will have a negative feedback. It will act on TR beta receptor in the hypothalamus pituitary. There will be a checkpoint. So it is reduced. And since TSH is not, when the T3 reduced, TSH is not increased, appropriate to low T3. So there will be a reduction in TRH in the hypothalamus also. So it will cause the reduced amplitude on nocturnal pulse of the TSH in the critical illness status. Also, the TSH is less glycosylated, so it is less biologically active. The stimulus for the thyroid is less for these TSH in critical illness. During illness or infection, like during illness like bacterial infection, lipopolysaccharide is secreted. It will cause interleukin 1 beta stimulation. That will directly cause the TRH suppression in the hypothalamus. So it will, TSH is reduced, T3, T4 formation is reduced. Also, lipoprotein lipase activate the NF-kappa beta. it will create the anterior pituitary deadenase D2 enzyme activity. So it will increase the conversion of T4 to T3 inside the pituitary. So the local T3 is increased inside the pituitary. So local T3 will act on the increased T3 available in the pituitary. So will act as a negative feedback loop on the TR beta in the pituitary. So we'll check on the TSH secretion. So TSH is reduced. So the axis is suppressed, T3, T4 formation is reduced. That's the mechanism in infection. Also due to some cytokines during inflammatory states. So the hypothalamo-pituitary thyroid axis is suppressed. The mechanism I showed, due to inflammation and infection, NF-beta will be stimulated inside the pituitary. So the D2 is stimulated. Deadenase D2 will convert T4 to active T3 inside the pituitary. So local T3 is increased inside the pituitary. It will act on the TR beta. It will inhibit the TRH. So the loop is on a negative feedback loop. Then about the role of nutrition. During starvation status, what happens? Usually TRH neurons in the hypothalamus is the set point of the hypothalamo-pituitary thyroid axis. TRH secreting neurons is influenced by the arcuate nucleus. Arcuate nucleus secrete the alpha MSH. Alpha MSH will stimulate the TRH and neuropeptide Y and agouti related peptide. It will inhibit the TRH. Leptin, which will prevent the inhibition of the neuropeptide Y and agouti related peptide and enhance the alpha MSH activity. So in 10, leptin will increase the TRH, increase the thyroid hormone secretion. But during starvation, hypocaloric status, what happens? The leptin amount is reduced in the starvation status. So leptin action is reduced. That will create the reduction in TRH via these mechanisms like neuropeptide Y and agouti related peptide. That inhibition is increased and alpha MSH stimulation is reduced due to the reduced leptin amount during starvation. That will in turn reduce the thyroid hormone levels. In total, hypothalamo-pituitary thyroid axis, like reduced leptin, will then increase cytokines, increased leptopolysaccharide, inflammatory status, will reduce the TRH, reduce THS, reduce T3, T4 formation. Second mechanism, what happens in the peripheral metabolism in thyroid hormone, about the thyroid hormone binding proteins. There will be rapid reduction in the thyroid binding globulin during sepsis due to the cleavage by the inflammatory serine proteases. So the binding globulin reduced, so the total T4 is reduced. There will be less affinity for T4 to the binding globulin. Total T3, total T4 is reduced during this status. FT3, FT4 is not affected due to these mechanism. Then other mechanism in peripheral metabolism like inhibitors will be present, which will inhibit the T4 binding to transport protein, like non-protein inhibitors, many drugs, and non-esterified fatty acids, which will inhibit the T4 binding to thyroid binding globulin. Drugs like high-dose furosemide, salicylates, it will directly inhibit the T4 binding to thyroid binding globulin. So that what happens? Free T4 is increased. When free T4 increased, there will be negative feedback loop acting on the pituitary. It will reduce the TSH release. So there will be a reduced TSH with increased FT4 status. Then heparin. Heparin, what happens? Sir? When long run, the TSH will be reduced and activity is reduced. Yes. Yes, sir. Yes. Then heparin, how it acts? Heparin don't act direct more than direct action. It has an indirect action. It will activate lipoprotein lipase. Lipoprotein lipase will degrade triglyceride into non-esterified fatty acid. Non-esterified fatty acid inhibit the binding of T4 to thyroid binding globulin. So it will increase the free T4. It will inhibit the TSH. So the hormone formation is suppressed due to these drugs. These are another mechanism for the reduced formation of thyroid hormones. Same. Actually, there is some other condition like cirrhosis, like thyroid binding globulin is reduced. Then these drugs can cause. Yeah. Yeah. That, but many articles mention that pharmacologic entities another set. Usually, it will manifest on thyroid TFT, but usually not considered as a non-thyroidal illness as such. drug interaction, pharmacologic interaction on thyroid function test is separate entity, as is mentioned like.
Because we cannot separately analyze these patients. So this might also be a cause for abnormal DFT, but this is not the sole reason. Just like in the previous slide, you mentioned cytokines and inflammatory cytokines increase the central migration. But they have done some rodent studies where they infused anti-cytokine, where they reduce the cytokine level, but this is not reverse side action. So this can be might be just some converts in a physical patient. So that can be some patients where we can find three people, and these drugs can influence this patient. That might not be a part of critical illness related changes in thyroid.
The reason I asked the question was that sometimes in critical illness situation when all the drugs are going, is it feasible that we can see a high uptake of situation also?
Yes, sir. One other entity was mentioned of acute pulmonary hepatitis. That will release TPG into the population and that will result in increased treatment. But that will not manifest that because the hormone proportion is not. In similar case, if we just see at the point that PT4 is this, and then subsequently that would not manifest, but that might be seen as just increased PT4. But actually.
Iodotheramine transport into the tissues also. Why? In cellular uptake, it's the rate limiting step of intracellular metabolism. During acute stress state, we have to preserve the calories. We have to reduce the oxygen consumption. The liver is the major site of T3 production and reverse T3 clearance. So transport into the liver is an active ATP dependent process. It will be reduced in the critical illness like hypocaloric stage and illness stage. So the transport into the tissues also reduced in this non-thyroid illness state. Then some chronic condition like CKD, CLD, there will be metabolites like indoxysulfate, bilirubin, non-esterified fatty acid, which will also inhibit the transport into the liver, into the tissue metabolism. So in these settings, we can see increased MCT8, MCT10 expression, which the transport proteins of these liver. This is the compensatory mechanism to increase the tissue availability of these hormones. This is also seen in this chronic condition, which suggests that tissue transport is reduced. But the deadenase mechanism, there are mainly three types of deadenase. D1 is present in the liver, kidney, pituitary, thyroid, which is present in the plasma membrane. D2 is present in the endoplasmic reticulum, which converts T4 to active T3. Then D3 is present in the plasma membrane, which converts T3 into inactive T2. It's an inactivating enzyme. The balance between D2 and D3 makes the availability of cellular T3 into the cellular availability of T3. What happens in non-thyroidal illness to these deiodinase? D1 in the liver and kidneys reduced. I will explain with a diagram. What D1 and D2 do? It will convert the T4 to active T3, D1 and D2. In non-thyroidal illness, this conversion is reduced. So the active T3 formation is reduced. Along with that, D3 is increased in these conditions. D3 will convert T4 to RT3, which is an inactive enzyme. This D1 also converts the reverse T3 to T2, metabolism of the reverse T3. So that when the D1 and D2 is reduced, D3 increased, there will be a state of low T3 with the increased reverse T3. So it will be the thyroid profile in the non-thyroidal illness. Okay. Yes, madam. Normally in the liver, D1 is converting T4 to active T3. So in non-thyroidal illness, this D1 activity is reduced. So the active T3 formation is reduced in the periphery. In the pituitary, I have told about D2. That is the local D2 only. That will convert T4 to T3 in the pituitary, so that T3 is available inside the pituitary. That will increase act as a negative feedback loop in the pituitary and reduce the TSH formation. This is in the periphery, mainly in the liver. Yes, ma'am. Local T3. Yes, ma'am. Yes. This is the peripheral deodenous mechanism. D1 is reduced, so the T3 active T3 is reduced in the periphery. So that along with that D3 is increased. So that T4 is metabolized into the reverse T3, which is an inactive metabolite. So the active T3 is reduced in the tissue. Same thing explained with condition. It can be affected due to infection, illness, cytokines. This deadenous mechanism is affected due to these conditions. Cytokines like IL-6, TNF-alpha, interferon alpha, it will suppress D1 activity in the periphery. So the active T3 formation is reduced in the periphery. These cytokines will stimulate the D3 also. So the reverse T3 is increased. So non-thyroid illness thyroid pattern will be seen, like low T3 with increased reverse T3. Same mechanism is seen in the hypoxia. During sickness, we want to reduce the oxygen metabolism to the peripheral tissues. So as an adaptation mechanism, HIF1 alpha will stimulate D3. D3 will convert T4 to reverse T3. So the active T3 is reduced and more of inactive product is seen in the periphery. Reverse T3 is hypoxia also manifests as same thyroid pattern. About the low selenium also reduce the deadenous activity. But trials showed that selenium supplementation in sepsis fails to improve the thyroid function. This mechanism in critical illness, low selenium is found out, which also manifests like non-thyroidal illness. In total, liver inside the liver, T4 to T3 conversion is reduced. T4 to reverse T3 conversion is increased. So that inactive reverse T3 is increased, active T3 is reduced in the periphery. It will be due to sepsis, cytokines, other like non-steroidal fatty acids, low selenium. It will also interact with this deadenous mechanism. What the pathogenesis about the nuclear receptor? During this illness stage, TR alpha and TR beta is reduced in the peripheral tissues, so that the nuclear uptake is reduced, peripheral activity is reduced. The inducing mechanism can be cytokine, interleukin 1 beta. Thyroid hormone is uptake into the thyroid response element. It has co-activator and ryanodine receptors, retinoid X receptor, which is also reduced in illness status. So that nuclear receptor status is in a deactivated state in this non-thyroid critical illness. So T3 formation is reduced. In total, it will act in the non-thyroid illness, will act in all the sites of these thyroid hormone formation like hypothalamus, pituitary, thyroid binding globulin, peripheral tissue uptake inside the deadenous mechanism, even nuclear mechanism. All these pathways affected in non-thyroidal illness. So multifactorial mechanism, multiple sites are affected in this illness. About when to suspect an intrinsic thyroid illness, the non-thyroid illness syndrome. When there is a normal TSH, we can exclude the hypothyroid or thyroid toxic status in these conditions. But when high TSH, we cannot say it is due to hypothyroidism. Like in recovering status of the non-thyroid illness, it can be mild elevation of TSH, we can see. But what are the conditions favoring the diagnosis of primary hypothyroidism in a patient with a non-thyroidal illness? Usually, a strong possibility is if the TSH is very much elevated, like more than 25 to 30 MIU per ml, it can suggest primary hypothyroidism is there along with this non-thyroid status. Presence of goiter, then positive anti-thyroid antibody status like TPO positivity, it will all suggest underlying primary hypothyroid status in non-thyroidal illness. When to suspect secondary hypothyroidism? I told isolated secondary hypothyroidism is very rare. So along with that, other anterior pituitary hormone deficiency like hypocortisolism, reduced plasma cortisol, which will suggest central hypothyroidism. Usually during illness status, sickness status, it will be a stress condition. Cortisol will be elevated. We can look into cortisol. When cortisol is normal or elevated status, it is more suggestive of non-thyroidal illness. This reduced status, we can suspect central hypothyroidism. When to suspect hyperthyroid status, the non-thyroid illness. Usually I told TSH will be reduced in non-thyroid illness, but usually it won't be undetectable level. When the TSH is undetectable level in ultra-sensitive assay, we can suspect an hyperthyroid status with underlying non-thyroid illness. And there will be increased serum free T4 and serum free T3 also. But there are some caveats, like some 7% of patients with non-thyroid illness, it is seen that some undetectable TSH is seen. Some patients like patients on dobutamine, dopamine like TSH suppressing drugs, most likely in ICU patient will be on. It can get undetectable TSH in non-thyroid illness status also. What are the clinical significance of this non-thyroid illness? Main clinical entities, it can suggest the prognosis in a critical illness patients. It may mimic other true thyroid status like secondary hypothyroidism. Other than that, main importance is low T3, low T4. We can predict the mortality in a critical illness patients. Like falling serum T3 will correlate directly with the amount of myocardial, quantity of myocardial infarction, the severity of sepsis, severity of chronic kidney disease like serum creatinine, then also burn severity. It will directly proportional to the critical illness status. How much sick is the patient? Falling serum T3 level. Yeah. Yeah. Or we can monitor gradually day 1, day 2, day 3, increase T3, low T3, then initial mild status. On going to severity, there will be reduced T4 also. Initial normal T4 going to low T4 status, we can suggest. Yes. Actually, mortality prognosis more likely, more when the sickness is more severe, it directly proportional to low T4. I will be coming to that. I wrote maybe low level actually. Low. Ma'am.
Whatever the lower value of the essay is, that lower value lower than that is considered as low. So it's not fall, it is a
low level. Okay. CKD, chronic kidney disease.
Can be an increase, but there will be reversal of the state. Until there's an acute complication. So it stays like that.
I'm not sure.
Because many actually get transplantation stuff in nephrology. They have only a very then I guess it would be like 8 or something, and nephrologists mostly start on thyroxine for those patients also.
Okay.
And it will depend on what is the quantity of proteinuria as well.
Oh.
If they have massive proteinuria, low albumin, automatically their total levels will be low. They have gross proteinuria.
I mean, does this say it's an acute rise in TSH, then you might wait for a while. If it is persistently elevated, then you can give thyroxine. That is what is been
So elevated means above 10 or above the.
So there is no cutoff given anywhere. But in up to date, there was mentioned that if it is less than 10 to 20 or more than 20, more than 20 with low levels give thyroxine. But it is between 10 to 20 and low T4, then you might wait for 1 to 2 weeks and see if that TSH comes down. Because most of the patients admitted will be either on acute or chronic CKD. They might have an acute that subsequent might come down. They say we can wait and watch for 1 or 2 weeks and then decide.
There is some correlation between the T4 level and sensitivity and specificity of prediction of mortality in these patients. Like serum T4 less than 3.1 microgram per deciliter can predict mortality with the sensitivity of 75% and specificity 80%. When we combine with serum cortisol level more than 30 microgram per deciliter, it can predict sensitivity with sensitivity 100% and specificity 82% for the prediction of mortality. So the level, as the sickness increases, serum T4 is the most important. As the worsening, it will be serum T4 more important than serum T3. So with T4 and serum cortisol, we can suggest sickness and prediction of the mortality. More as sickness increases, low actually the individual value of load T4 is more important, directly correlating with initially mild status will be low T3 syndrome. We can suspect worsening on monitoring. Yeah, that's. Question is whether the treatment is needed or not for these conditions. Like there are many randomized clinical trials conducted for these patients, like non-thyroid illness, like many clinical settings, like post-cardiac surgery, CABG patients, kidney transplant patients, then congenital heart surgery patients, nephrotic syndrome patients. Most of the studies showed like CABG patients, they treated with IV T3 initially. Post aortic clamping, they have given bolus IV T3 with for 6 hours. They have continued T3 infusion, but it increased the cardiac index cardiac index, like peripheral resistance was reduced and cardiac index increased from 2.67 to 2.97 compared to placebo. These values show significance, but on the long run, there was no benefit in the ICU stay, no benefit in the mortality, no benefit in the as such clinical benefit was not seen. Only biochemical benefit like cardiac index improved, peripheral resistance status was improved. Clinically, that was not beneficial. No evidence of to suggest that T3 treatment for these ABG patients from these studies. Then there are many studies like nephrotic syndrome, preterm infants. They are treated with the T4, but these studies suggest no evidence to suggest the treatment in these conditions, like preterm infants for the development of problems. Then other modalities of treatment, newer modality like co-infusion with TRH, which growth hormone P2, GHRP2. It shows a newer modality of treatment. TRH will restore the pulsatility of the THS release. It will be anabolic, the less catabolic, and it will be improved in the critical illness status. But it requires more larger scale randomized control studies. As such, no proven benefit for now for the TRH and GHRP2 co-infusion. For conclusion, non-thyroidal illness status is a multifactorial entity in a critical illness patient. It can affect from hypothalamus to peripheral metabolism, like even nuclear receptor. There is central and peripheral mechanism acting at multiple levels. Then it's thought to be adaptive mechanism in a critical illness state to benefit in the acute state, but in the long run, it will behave as a maladaptive status. Then the most important thing is it has a prognostic value in critical illness, like serum T4 less than 3.1 predict the mortality in these patients. Whether to treat or not to treat, as such, no evidence available till now. Needs more randomized control studies and further large-scale studies. The newer modality